Hello everyone. Welcome back to the series of lectures in neurology. So in the last few sessions, we have learned about the basics. We have learned about UMN versus LMN and we have learned about the approach to stroke. So in today's session, we will be dealing with a very interesting and conceptual topic, which is your localization of stroke. So let's begin. So what is this diagram showing? This is nothing but your circle of Willis. This is nothing but your circle of Willis. So before understanding how do you localize your stroke, so you will have to understand the vascular anatomy of the brain, and you will also have to understand how each vessel, when it is blocked, what kind of symptoms will happen. Okay. So predominantly the circle of Willis comprises of two major arteries. Okay. The two major arteries which contribute to the formation of the circle of Willis is your vertebral artery and your internal carotid artery. So the two major arteries which contribute to the formation of the circle of Willis is your vertebral artery and its branches and the internal carotid artery and its branches. Okay. So as you can see here, the vertebral arteries, the two vertebral arteries join together to form the basilar artery. Okay. The two vertebral arteries join together to form the basilar artery. The basilar artery moves ahead and it is at the level of the pons. Okay, the two vertebral arteries join together to form the basilar artery, moves ahead at the level of the pons, and the basilar artery finally divides into two branches, which is your two posterior cerebral arteries. PCA stands for posterior cerebral arteries. Okay, fine. So, arising from the vertebral artery are other branches. What are the other branches? You have a anterior spinal artery. The anterior spinal artery goes downwards and supplies the anterior two-thirds of the spinal cord. It supplies the anterior two-thirds of the spinal cord. Okay. Then you have a posterior inferior cerebellar artery, which is your pica. The pica supplies the lateral part of the medulla. It supplies the lateral part of the medulla. Then as you go up, you can see that you have the anterior inferior cerebellar artery. So what do you think is the structure that is coming here? It is the inferior pons. Okay, it is the inferior pons. Then we have the labyrinthine artery or the auditory or the internal auditory artery. So the labyrinthine artery is a branch of the ICA and it supplies the vestibular nucleus. It supplies the vestibular nucleus. What is the clinical significance of the labyrinthine artery? So we know that the labyrinthine artery supplies the vestibular nucleus. So if the vestibular nucleus is damaged, you will have vertigo. You will have vertigo. So every time that a patient presents to you in the OPD, you will have to know if this is a central cause of vertigo or a peripheral cause of vertigo. Peripheral cause means probably because of a BPPV, which is your benign paroxysmal vertigo, or is it because of a central cause because of stroke? So labyrinthine artery, when it has a stroke, if there is an embolus or a small stroke which affects only the labyrinthine artery without any other signs, then it can mimic a peripheral vertigo to a large extent because of vestibular nucleus involved. Okay, clear? Then arising from the basilar artery, we have a lot of pontine branches which supplies major portions of the medial aspect of the pons. Then we have the two posterior cerebral arteries. So till now, whatever we discussed, the vertebral artery and the basilar artery, which is your vertebro-basilar system, is called as the posterior circulation. It is called as the posterior circulation. Okay. Then we will look at the internal carotid artery. So you can see this major artery here is the internal carotid artery. The branches of the internal carotid artery, the two major branches that you have to remember are the anterior cerebral artery and the middle cerebral artery. Okay, anterior cerebral and middle cerebral. So these are the major branches which help in the formation of circle of Willis. Okay, so fine. Now, what are the communicating arteries? So you have a posterior communicating artery which is basically present between the internal carotid and the PCA. It helps in completion of the posterior part of the circle of Willis. Then we have the anterior communicating artery which is present between the two anterior cerebral arteries, ACA here and ACA here, and between that you have an ACOM. Okay, fine. So this is about your communicating arteries, right? So what are the two major branches of ICA which help in the formation of circle of Willis? We have the anterior cerebral artery and the middle cerebral artery. Then we have other branches from the internal carotid, including the PCOM, which helps in completion. So we have the PCOM, then we have the anterior choroidal artery, and the ACOM, which is your anterior communicating artery, is basically present between the two branches of the ACA, two sides, which are the two branches from the ICA or the connecting the two ACAs. Okay, so what we discussed here, the internal carotid artery and its branches including MCA and ACA is your anterior circulation. Okay, so what does the ACA, MCA supply? The ACA, MCA are going to supply various parts of the brain. Okay, it's going to supply various parts of the brain including the cortex. Okay, where does it supply? How? That we will be looking. So the pons medulla is predominantly and including the branches of the brainstem. The brainstem is right in the center here, right? So including parts of the brainstem is supplied by the posterior circulation. The rest of the cortex is supplied by the anterior circulation. Okay, so clear till here. Now let us look at ICA syndromes. Let us look at your internal carotid artery syndromes. So if there is an occlusion of the internal carotid artery, what are the symptoms and signs with which they are going to present with? So first let us understand what are the branches of the internal carotid artery. The branches of the internal carotid artery are given by the mnemonic OPAM. So O stands for ophthalmic, P stands for posterior communicating, A is your ACA, M is your MCA, and the other A is your anterior choroidal. Okay, so remember that the branches of the internal carotid artery are given by the mnemonic OPAM, which is ophthalmic, posterior communicating, anterior cerebral, middle cerebral, anterior choroidal. So let us look at the symptoms with which they present, right? So first branch of the internal carotid artery is your ophthalmic artery, which is going to go and supply to the retina. So if there is an obstruction here, as you can see here, there is a clot which has gone and dislodged into your ICA, or if there is an atherosclerotic plaque which has obstructed your ICA, then what will happen? Ipsilateral ophthalmic artery, the flow will be reduced, right? If the flow is reduced, they can have transient blindness, and this is what we call as amaurosis fugax. Amaurosis fugax, basically they feel like a curtain has fallen and gone. So they have transient blindness in your ipsilateral ICA occlusion because of decreased blood flow through your ophthalmic artery. Okay, so that's your amaurosis fugax. In fact, when you go for your clinics, you will be taught that amaurosis fugax is one of the signs of anterior circulation TIA or anterior circulation strokes. This is the reason. Second, what happens if a patient has hypertensive retinopathy? Okay, so whenever a patient has hypertension, he can have changes in the eye that we call as hypertensive retinopathy. Okay, now patient of hypertension with hypertensive retinopathy has developed one-sided carotid artery occlusion, right? So what happens to the blood flow in that side of the ophthalmic artery? It is going to decrease. Now if it is going to decrease, then what is going to happen to the hypertensive changes in that eye? So hypertensive changes in that eye will also be reduced. So there is a reduction of hypertensive changes in the eye in the diseased side or affected side. So if you have a right-sided carotid occlusion, then your right side eye hypertensive changes will be reduced. Okay, clear. Another very important point is your flow reversal. So if you do a Doppler and you see the blood flow, in the ophthalmic artery. In the ophthalmic artery, there will be blood flow reversal. Why is that so? Because there is a block here and hence the blood flows in the opposite direction, and this is a characteristic sign on Doppler suggesting an internal carotid artery stenosis. Okay, so flow reversal in the ophthalmic artery, right? Also, now there is a block here. What is the tendency? Whenever there is a block, you take another route. You take a parallel route, right? You take a parallel route to ease the congestion, right? So if there is a congestion here because of the block, then the blood gets diverted through the other parallel routes, and what is present here? This is your ECA. So if there is a block in the internal carotid artery, there is more flow directed towards the external carotid artery, and because of the increased flow through the external carotid artery, you get a lot of pulsations in your face, right? The external carotid artery is a major arterial supply of the face. You get the facial artery from there, right? So that is what we call as the ABC sign. Okay, so what is ABC sign stand for? It is angle, brow, cheek sign. Okay, so angle, brow, cheek sign means increased pulsation at the level of the angle of the jaw, increased levels of pulsations in the brow, increased pulsations in the cheek area, in the brow area. So that is your ABC sign. Because of ICA stenosis, there is increased blood flow to the external carotid artery. Then never forget to auscultate a patient. You always know that we tell about vessels in your CNS examination in the end, right? We talk about the spine, we talk about the vessels. Why do we talk about that? Because we can auscultate for bruits. We can auscultate for bruit in the internal carotid artery, and if it is present, it is suggestive of a stenosis. Okay. So this is how an ICA tertiary occlusion can happen, right? Of course, you can have signs of your if your ICA is completely occluded, the branches of the MCA and ACA are also affected, so you can have a massive stroke. But these are the other changes which you have to remember. Suppose the patient is presenting with TIA and not a stroke, then these are the other changes which can help in picking it up early, right? So if there is an ICA TIA, which is a transient ischemic attack, then these are the other changes that you can look for before they present with a massive stroke, right? So these are the changes. You can have transient blindness, which is your amaurosis fugax. You can have decreased hypertensive retinopathy changes, flow reversal, increased flow in the ECA. In auscultation, you can have a bruit. So this is. Now let us move on to your anterior cerebral artery or your ACA circulation stroke and its features. Clear? Fine. Now ACA, whenever we talk about the anterior cerebral artery, it is divided into two parts as A1 and A2. So A1 is basically that branch which arises before the anterior communicating artery, and A2 is that which arises after the anterior communicating artery. So I will just show you that here, right? So can you see here that this is your ACA, this is your ACA. So the segment which arises before the ACOM, right? The segment which arises before the ACOM, where is the ACOM? This is the ACOM, is your A1, and this segment is your A2. Clear? So clear about what is A1 and what is A2? Okay, fine. Now let us understand what are the clinical features. So before we understand the clinical features, let us see the different sections of the brain, your anterolateral surface, superior surface, your medial surface and inferior surface. How is the ACA territory distributed? So what are the areas of the brain which are supplied by the ACA? So if you go back to your neuroanatomy classes and you compare those diagrams, you will understand it. But here I am not going into that much detail about which branches of the artery is supplying which area, because it will get really confusing. So I am talking in terms of areas which are supplied. Okay. So in the anterolateral surface of the brain, you see that there is a small strip in the superior region which is supplied by the anterior cerebral artery. On the medial surface of the brain, so this is your small strip, okay, small strip which is supplied by the ACA. Then in the medial surface of the brain, it basically supplies your orbitofrontal cortex, as you can see highlighted here. So your ACA is going to supply your orbitofrontal cortex. Okay, so it's going to supply your orbitofrontal cortex, it is going to supply your cingulum, it is going to supply your anterior portion of the corpus callosum, and we know that there are certain important areas here. So what are the important areas? The important areas include amygdala and hippocampus, which are involved in memory processing. Okay, so all of these structures are supplied by the ACA, right? In the inferior surface, again you have a small strip medially which is supplied by the ACA. Okay, so these are the areas which are supplied by the anterior cerebral artery. So please have a picture memory of these areas so that you will understand each of these symptoms even more clearly. Fine? Okay. So first symptom, there is weakness. Okay. So in an ACA territory infarct, what kind of weakness will you have? Now why is there weakness? As you can see here, in an ACA territory infarct, the small strip of your superior surface is affected, and there you have your motor cortex and sensory cortex, right? So you have your motor cortex here and your sensory cortex. So because of involvement of the motor cortex, you can have weakness. Okay, and what sort of weakness will you have? So I have shown you here what is this structure, this diagram. This is a motor homunculus. Motor homunculus. What is the meaning of a motor homunculus? So homunculus is basically a diagrammatic representation of various parts of the body and which part of the brain controls what part of the body to what extent. So this is exactly what it is showing. So on the coronal section of the brain, what is highlighted is your ACA territory supply. So this is this area supplied by the anterior cerebral artery. So if there is an infarct, which part is going to get affected? It is predominantly, as you can see here, it is one limb. It is predominantly, as you can see here, it is one limb, and this is what we call as crural monoparesis. This is what we call as crural monoparesis. So in an ACA territory, in fact, you can have which contralateral or ipsilateral? Contralateral. You can have contralateral crural monoparesis, and we have understood why. Okay. Then you can have contralateral sensory loss as well, because involvement of your sensory cortex is also there. You do not get a dense hemiplegia, or you do not get a hemiplegia as such. When we discuss about MCA territory, you will know the reason being only a small part of your cortex is involved. Okay. Now, third, there can be involvement of the structure that we call as paracentral lobule, which is present in the medial aspect of the brain. Now the paracentral lobule is responsible for your bladder control. So there is loss of bladder control, and you can have urinary incontinence. You can have urinary incontinence in your ACA territory infarct because of involvement of the paracentral lobule. Okay, but we know that the ACA territory is supplied by two. Right? There are two ACAs. So if there is bilateral ACA territory involvement, more likely you are going to have urinary incontinence. Then orbitofrontal cortex and cingulum involvement. So if there is orbitofrontal cortex and cingulum involvement, what all are the functions? What are all the functions of orbitofrontal cortex and cingulum? They are responsible for energization. They are responsible for energization. Right? So if the cingulum is lost, if the cingulum is affected, there is no energy, and this symptom of amotivation or loss of energization is what we call as apathy. So the patient will be very apathetic. They do not have any motivation to any work. There is no energy in them. And a more serious form is what we call as a more serious form of apathy is called as abulia. A more serious form of apathy is called as abulia. Okay, so the patient will not have any kind of interest in any activity, and they will just be looking at, staring at you. So that is your apathy and abulia, amotivation, which is seen in your ACA territory infarct because of involvement of your orbitofrontal cortex. Then because of involvement of the orbitofrontal cortex and cingulum. Then there can be involvement of the amygdala, hippocampus. That's what we have discussed now. So if there is involvement of the amygdala, hippocampus, there can be memory disturbances as well, right? Also, involvement of the orbitofrontal cortex can result in the formation of what we call as release reflexes. Okay, so you can have contralateral release reflexes. What is the meaning of release reflexes? So we know that there are certain neonatal reflexes which is there as a part of a normal human body. There are neonatal reflexes in your neonatal period, right? So what are those reflexes? This is sucking reflex, rooting reflex, glabellar tap, right? So what is that? Sucking reflex, rooting reflex, glabellar tap, right? Sucking reflex is a reflex which helps an infant to drink milk. Similarly, your rooting reflex as well. So these reflexes, as the child grows, it is lost. It's not present beyond a particular age. But in lesions of your orbitofrontal cortex, you can have these signs coming back, right? So you can have these reflexes in the contralateral side because of damage to your orbitofrontal cortex, and this is what we call as release reflexes. So you can have a contralateral sucking, rooting reflex and so on. Okay, fine, right. Also, there is a gait center here. There is a frontal control of gait which is present. So when there is a frontal damage, the frontal control of gait is lost, and you can have something called as gait apraxia. You can have something called as gait apraxia or magnetic gait. Okay, you can have magnetic gait. This is also seen in another condition, which is your NPH or your normal pressure hydrocephalus, right? Fine. Then there can be corpus callosal involvement, right? So the anterior limb of the corpus callosum is involved. Because of damage to this, you can have dyspraxia. As dyspraxia or apraxia means inability to perform a learned motor activity. Inability to perform learned motor activity. So there can be dyspraxias. Then aphasia. What type of aphasia will you get? So the predominant area is the orbitofrontal cortex, right? So it is not damage to your Broca's area or Wernicke's area per se. It is predominantly damage to your association areas. So because of association areas which are affected, you can have transcortical aphasia. What type of aphasia? Transcortical motor aphasias are common in ACI tertiary infarcts. Okay, so this is very, very clear. So we have crural menoparesis, we have sensory loss contralateral, paracentral lobule, you can have urinary incontinence, then your abulia, apathy, then you can have transcortical motor aphasia. So if you memorize all of this, you will not understand. That is the reason why these simplified diagrams are given, and under each of these diagrams, each area affected, you will get these symptoms, and this is how it has been explained. Then if there is an unpaired ACA, that means we know that from the right side and from the left side we have one ACA which comes together and they are joined together by the ACOM, just now we have seen. But in some conditions there can be an unpaired ACA, only one ACA is supplying both the sides. So one ACA is supplying both the sides. If that gets affected, what will you have? You will not have monoparesis, rather you will have paraparesis. You will have paraparesis because both the limbs will get affected. So every time we speak about paraparesis, we have learnt in our approach to basic neurology as well, paraparesis we localize to spinal cord. So a cortical cause for paraparesis, if anyone asks you, it is an unpaired ACA tertiary infarct. Okay, it's an unpaired ACA tertiary infarct. Clear? So this is about your ACA territory. So now let us move on to MCA territory. Okay, so MCA is your middle cerebral artery. So MCA and its branches, when you take a coronal section, it can be divided into 4 parts. Okay, it can be divided anatomically into 4 parts. So M1 is your horizontal segment. M1 is your horizontal segment. Then we have M2, which is going through the insula. Then we have your M3 segment, which goes through the operculum. Can you see here? This is the M3 segment, and M4, which basically moves on to the cortex. Okay, so this M1 segment is basically present in the sylvian fissure. Then you have the M2, M3 and M4. So the horizontal segment is your M1 segment. So depending on which branches are involved, you can have different symptoms. So if the M1 branch is involved, right? So if the M1 branch of your MCA is involved, you can see that the M1 segment gives rise to multiple other small branches which basically penetrate deep into the white matter of the cerebrum, and they supply the white matter basically, and these are small branches. So M1 affection can actually cause lacunar strokes. So M1 is predominantly associated with lacunar strokes. But as you can see, the M2 is the main branch. So if the M2 is affected, large areas of the cortex can be involved. So whenever we talk about the major symptoms of an MCA infarct, it is usually due to your M2 affection. So it is usually due to M2 being affected, and that is what we will be looking at in detail. Now, M3 is going through what? It goes through the operculum. Now, I would just like you to focus on the homunculus again. So, if you see in the motor homunculus, this is your operculum, correct? This region which I am highlighting here is your operculum, correct? So, can you see what are the regions which are supplied here? It is predominantly the larynx and the pharynx. It is predominantly the larynx and the pharynx, right? So, opercular infarct. So, opercular infarct, whenever there is an M3 or an opercular infarct, it can result in what? It can result in stridor. It can result in weakness of your larynx and pharynx. It can result in stridor. It can result in dysphagia. It can result in dysphonia. So, an M3 opercular infarct, especially if it is bilateral, it can be very confusing with a brainstem stroke. Fine. So, till here it is clear. We have understood M1, M2, M3 and M4. Now, let us look at your M2 syndromes a little bit more in detail. Okay. So, the M2, as it comes out here. It goes through the sylvian fissure. So, the stem of the M2 passes through the sylvian fissure. Okay. The stem of the M2 passes through the sylvian fissure and it divides into a superior division and an inferior division. So, this is your M2 branch and the stem passes through the sylvian fissure and it divides into a superior division and inferior division. Now, if there is an occlusion at the M2 stem, then what are the symptoms that you can have? That is what we are looking at. So, if you can see, we have highlighted the various regions which are affected by the middle cerebral artery. So, in your lateral surface of the brain, which are the regions which are affected? So, I told you only a small strip is supplied by the ACA. So, the yellow is by the ACA and almost the rest of the lateral surface of the brain is supplied by the MCA. Okay. But as compared to ACA, which supplied a huge part of the medial aspect of the brain, a very small portion which is called as your frontal pole, is supplied by the MCA, predominantly your M2 branch. Then on the inferior surface, you can see here, so it is predominantly the areas of some parts of the parietal lobe, some parts of the lowermost temporal lobes and the optic radiation. What comes out here is your optic radiation. So, optic radiation is supplied by the MCA. Okay, fine. Okay. Now, let us understand the symptoms of an M2 occlusion. So, M2 stem occlusion. Then we will look at the superior division and inferior division symptoms separate. So, the symptoms of an MCA infarct have to be classified based on whether the dominant cortex is affected or the non-dominant cortex is affected. So, what do you mean by dominance? Dominance means that in simple terms, you will already be aware a right-handed individual has a left dominant cortex. So, the area which is involved in most of the activities including language is your dominant cortex. Okay. So, the area which is involved with your language is your dominant cortex and the other is your non-dominant cortex. So, in a right-handed individuals, which most of the individuals are, it is a left dominant cortex, but doesn't mean always that a left-handed individual will have a right dominant cortex. It can be a bidominant cortex as well. So, for simplicity's sake, let us understand that the language area where it is present is your dominant cortex and the other is your non-dominant cortex. So, if there is dominant cortex involvement, the most common dominant cortex is left dominant, right? So, most of the language areas are present in the left cortex. So, if there is a left MCA, let us understand this dominant involvement, which means that left MCA. Okay. Now, motor cortex will be involved. Yes, why? Because as you can see here, the motor cortex is here and you have the sensory cortex right behind it. So yes, both the motor and the sensory cortex will be involved. So what is the symptom that you will have? You will have contralateral. You will have monoparesis or hemiparesis. You will have hemiplegia because a large aspect of the brain is involved. You will have contralateral hemiplegia, right? Because the corticospinal tract desiccates at the level of the medulla and goes downwards, we know that there will be contralateral hemiplegia. Then sensory cortex involvement, contralateral hemisensory loss. Contralateral hemiplegia, contralateral hemisensory loss. Then there is another area which is present here, which is called as area number 8 according to your Brodmann's classification, area number 8. So that is your frontal eye field. So what is the action of this frontal eye field? The frontal eye field is basically involved in the control of saccades. It is basically involved in the voluntary control of saccades. What are saccadic movements? Saccadic movements are rapid movements according to the movement of the object your eye moves, right? If someone calls you, you look that side. If something is moving, you suddenly move your eyes that side. That is a rapid movement which is called as your saccade. And the frontal or the control, central control of your saccades is brought about by the frontal eye field. Okay, so frontal eye field is responsible for the movement of eyes towards the opposite side. So it's responsible for the opposite side saccade. So if your left frontal eye field is affected, you cannot look to the right. The right sided saccadic movement is lost and hence the eyes are again pointing towards the same side. So frontal eye field lesions will result in eye pointing towards the affected side. Clear? Then language areas, like I told you, dominant hemisphere involvement will cause language disturbances. So as you can see here in your M2 lesion, what are the two language areas which are going to get affected? We know that the Broca's area is in your, can you see the Broca's area is in your inferior frontal lobule and your Wernicke's area is in your superior temporal lobe, right? So superior temporal gyrus and inferior frontal gyrus are Broca's and Wernicke's. If the stem is affected, both Broca's and Wernicke's will be gone. So we are talking about M2 stem involvement. You will have global aphasia. Okay, right. Then hemianopia. You can have hemianopia, predominantly a contralateral hemianopia. You have a contralateral hemianopia. Because of optic tract involvement, you can have contralateral hemianopia. Then you will recollect from your neuroanatomy that there is a gyrus which is present. So you have a temporal sulcus which moves on and goes and follows into a gyrus present in the parietal lobe, which is called as your angular gyrus. Now, what is the function of this angular gyrus? This angular gyrus is basically helping in reading, okay, and it helps in writing to a certain extent as well. So it helps in reading and writing. So if angular gyrus is involved, angular gyrus of what? Angular gyrus only in the dominant hemisphere, you get a condition which is called as alexia with agraphia, means inability to both read and write. So there is inability to read and write. So that is your alexia with agraphia, which is because of your dominant hemisphere angular gyrus involved. Then another very important syndrome is your Gerstmann syndrome, which occurs in your dominant hemisphere involvement of MCA. So this is predominantly due to involvement of the inferior parietal lobule. So this is your inferior parietal lobule due to involvement of the inferior parietal lobule. So what are the characteristic features that you have to remember? You have finger agnosia. 1. What is finger agnosia? Inability to name your fingers. If I point here, you know this is index finger, middle finger, but they have that kind of a confusion. Then acalculia, agraphia. Why? Inferior parietal lobule also includes your angular gyrus. So there is acalculia, agraphia and right-left confusion. They will have right-left confusion. So these are the characteristic features of Gerstmann syndrome. Okay, so we have understood what are all the characteristic features of dominant hemisphere MCA stem involved. So we have understood what are the dominant hemisphere MCA stem involved. Now, if there is an MCA infarct in your non-dominant hemisphere, so for example in a right-handed individual, right-sided MCA infarct, what are the features that you can have, right? So the additional features, you can have motor cortex, sensory cortex involvement, but additional features The additional features that you have is prosody of speech, right? So we told you that language is in the dominant hemisphere. So if there is non-dominant involvement, your Broca's-Wernicke's area is not going to be affected, but prosody of speech will be affected. What is the meaning of prosody? It means the rhythm in which the patient is talking, that is going to be lost. Then, because of the involvement of the non-dominant parietal lobe, you can have apraxias. Apraxias we had learned in your ACA territory as well. Apraxia means inability to perform a learned motor activity. So they can have dressing apraxia. Then anosognosia. What is anosognosia? It is denial of the defect. Denial of the defect. They are deny that they have any problem, that is anosognosia. Okay, so they can have anosognosia. Then hemineglect. Okay, so let us understand this concept of neglect. Okay, the neglect is basically a function of your parietal lobe. So right parietal lobe scans both the left side as well as the right side. So right parietal lobe scans both areas, right side as well as the left side. The left parietal lobe scans only the right side. The left parietal lobe scans only the contralateral right side, whereas the right scans both. Okay. So if you have a dominant hemisphere lesion, for example, in a right-handed individual, you have a left, most of the time left is your dominant. So if you have a dominant hemisphere lesion, what happens? Will you have neglect? No, because the right and left side is supplied by the right side with a parietal lobe which is intact, right? So in a dominant lesion, when I discussed about the dominant hemisphere changes, there is no neglect. But what happens when you have a non-dominant MCA infarct, which means there is involvement of your right parietal lobule. So right parietal lobule, as you can see, supplies both the sides. Okay, so it supplies the right parietal lobule is going to scan both the sides of your environment, the right side as well as the left side. But the left side gets only supply from the right parietal lobule. So left side and right side are going to be affected. Okay, but because the right is getting bilateral supply from both the right and the left parietal lobe, you will have a left hemineglect. You will have a hemineglect predominantly in your left side. Okay, so whenever you have a non-dominant, which means right MCA infarct, the patient is going to have neglect of the left side. Okay, because the only supply of the left side is from the right side. But when it comes to the right side of your environment, it gets supply from both the cortexes, gets supply from both the parietal lobes. So you never get neglect, very rarely in your right side. So most common, and the reason for this is because of your unilateral supply. So you get a left-sided hemineglect in your right-sided parietal infarct or a non-dominant hemisphere involvement. So clear, this is about your concept of hemineglect. So in a hemineglect, how will the patient be? The patient will have gaze preference. He keeps looking to this side because he is neglecting this half of the body. He is neglecting this half of the body. He keeps looking to this side. That is your hemineglect. Okay. So if the patient is okay enough to stand and do something, how will you assess for neglect? If you ask them to draw a clock, they will draw the half clock. They will draw the arrows for the clock as well, only on one side, other side will not be drawn. So that is how you assess for neglect. Clear? So left-sided hemineglect is a feature of non-dominant hemisphere involvement. You can have anosognosia, prosody of speech is lost, you can have dressing apraxia. So this is about your MCA syndrome, predominantly the stem. Fine. Now let us understand if the superior division or the inferior division is separately involved, then how will it present? So this is your stem of MCA, this is your superior, this is your inferior division. Okay, so it's clear here. Or shall I use another color? So superior division, inferior division. So if superior division alone is involved, so let us look at the supply in the motor cortex. So let us understand the weakness pattern. So this is where your superior division is. So you have your M1, you have your M2, and this is your superior division, this is your inferior division, then it continues as your M3 in the operculum, correct? Fine. So superior division, this area is affected. This is the area which is affected in your superior division. Which part of the homunculus is it supplying? It is supplying predominantly the contralateral hand and contralateral face. So if there is a superior division involvement alone of your M2, we are talking about M2. M2 is your second branch of MCA or second segment of MCA. Only the contralateral hand and face is involved, and this is what we call as your faciobranchial weakness. Then sensory cortex will be involved, yes, because this part of the sensory cortex is involved motor sensory. You will have contralateral hemisensory loss. Right? You will have contralateral hemisensory loss. Then which area is affected? Which area is going to be affected as far as the language is concerned? Yes, it is the area which is present in the inferior frontal lobe, which is your Broca's area. So you will have Broca's aphasia in isolated superior division M2 involvement. Okay, then let us look at the visual field defects. So there is involvement of the optic radiation. There is involvement of the optic radiation, right? So if there is superior division of M2, basically supplies the superior optic radiation, right? This part of the optic radiation. Okay, so whenever you have only the superior part of the optic radiation affected, then what type of hemianopia you will get? You will get a inferior quadrantonopia or the pie on floor appearance, right? So this is your inferior quadrantonopia or pie on floor. Correct? Because only the superior part of your optic radiation is affected, not the inferior. So you can have inferior field defects. Okay, fine. Now inferior division. Inferior division, as you can see here, it is this portion which is getting affected. So will there be any weakness? No, there will be no weakness. There will be no weakness. It's a very, very, very important point. Okay, fine. And what sort of a language disturbance will you get? Inferior division is supplying what? You will get a Wernicke's aphasia. You will get a Wernicke's aphasia, and the visual field will be a pie in sky. Pie in sky. Okay, so you have a pie on floor, pie in sky is in inferior. So you get superior quadrantanopias in inferior division of M2 branch affection. Clear? Now we will revise whatever we have learnt till now before we move on to your posterior circulation strokes. Right? So, fine. Now we are looking at the middle cerebral artery. Now the entire territory is involved. Can you see here the stem is involved? So such a huge area is affected. Clinical features will be contralateral gaze palsy that we already saw, hemiplegia, hemisensory loss. There can be neglect, there can be hemianopia, global aphasia, right? Depending on which hemisphere is involved. Is it dominant or is it a non-dominant side? So if you go through this, you might find it very difficult to remember. If you understand the reason for it, it is easier to get. Right? Now let us understand your superior division. This is not required, and inferior division. So superior division, like I told you, it is this region. So you have contralateral hemiplegia, hemisensory loss, gaze palsy and Broca's aphasia. Okay, in your inferior division, you can have Wernicke's aphasia, you can have apraxia or dyspraxia if your non-dominant hemisphere is in. Right. So this is clear. Now ACA territory, what are we having? We are having incontinence, we are having hemiplegia or monoparesis. Most often monoparesis, abulia, transcortical aphasias that we learnt. Why? Because the association areas are affected. Okay, fine. So this is about the various types of affections of anterior cerebral artery and middle cerebral artery. Now let us move on to PCA territory, which is your posterior cerebral artery strokes. So PCA can be classified into two segments as your P1 segment, which is before the origin of PCOM, and P2 segment, which is after the origin of PCOM. So can you see here that this is your PCOM. Okay, so this is your posterior communicating artery. Okay, so this region is your P1 and the one after that is your P2. Now let us understand the symptoms. So what is the P1 supplying? So P1 basically supplies what? As you can see here, these are the branches of P1. It supplies the midbrain and it goes and supplies the thalamus as well. So this is the thalamus and the midbrain. So it supplies the thalamus, the midbrain and the subthalamus which is present here. So the P1 segment basically supplies the thalamus, midbrain and the subthalamus. Okay. So the penetrating branches are the one which basically go ahead and supply deep into the thalamus. So what are the symptoms of your P1 stroke? You will have midbrain symptoms depending upon what areas of the midbrain are involved, right? So what is the characteristic feature of a midbrain stroke? You have a crossed hemiplegia. You can have a crossed hemiplegia which can be seen with P1 strokes. Then thalamus involvement. Thalamus involvement can result in a peculiar type of stroke, what we call as your Dejerine-Roussy syndrome. Dejerine-Roussy syndrome is basically contralateral burning sensation, paresthesias because of thalamic involvement. Okay. So involvement of the subthalamus. Subthalamus is basically involved in movement coordination. So disturbance to the subthalamus results in a hyperkinetic movement disorder that we call as hemiballismus, which is characterized by rapid flinging proximal movements of one side. Okay, so this is about your P1 strokes. Okay, so P1 strokes can cause your thalamic Dejerine-Roussy syndrome, it can cause hemiballismus, it can cause midbrain symptoms as well. Now, P2. What is the P2 supplying? It's P2, as you can see here, is supplying predominantly the medial part of the temporal lobe. It is supplying predominantly the medial part of the temporal lobe. And it supplies the areas which are there, including your optic radiations and posterior part of the optic radiations and the occipital cortex. Okay. So what are the symptoms of P2? So P2 can cause a contralateral homonymous hemianopia. We had learnt about homonymous hemianopia in MCA strokes as well, but they do not have this peculiar feature that we call as macular sparing. So this is contralateral homonymous hemianopia with macular sparing. Contralateral homonymous hemianopia with macular sparing is a characteristic feature of P2 syndromes. Then we know that the P2 basically supplies the medial temporal lobes. Also, which are the areas which are involved in your P2? This includes your inferior part and medial part of your temporal lobe. Inferior and medial parts of the temporal lobe and parts of the occipital cortex. So because of your medial temporal lobe involvement, there are certain other important structures which can be affected, including your hippocampus. So hippocampus plus medial temporal lobe involvement. Medial temporal lobe involvement results in what? It results in memory disturbances. Okay. Then we have a type of aphasia which can happen mainly because of your MCA-PCA watershed area, which is your association areas of your Wernicke area. So what type of aphasia you will have? You will have a transcortical sensory aphasia. Then another very important characteristic feature is the presence of a peculiar syndrome which is seen here. This is called as a peduncular hallucinosis. Okay. So whenever there is involvement of the thalamus and midbrain, thalamus plus midbrain in more so in your P1 syndromes, when there is a stroke, the midbrain and thalamus get straddled because of this increased pressure which is created with the stroke, and it causes a peculiar type of syndrome that we call as peduncular hallucinosis, which is characterized by visual hallucinations. Okay, so these are about the various features of your PCA strokes. So when it comes to P2, we have to remember contralateral homonymous hemianopia with macular sparing. There can be memory involvement because of your medial temporal lobe. There can be transcortical sensory aphasia. Okay, transcortical sensory aphasia, and we have understood what is peduncular hallucinosis. Now we will be looking at certain named syndromes, certain named characteristic syndromes. First, what is the top of the basilar artery syndrome? That means that when you see here, we have the two vertebral arteries which join together to form the basilar artery, and the stroke is somewhere here. So if I just draw it to you again, this is your two vertebral arteries, basilar arteries, and then we have the two PCA branches which are coming from here, and the stroke is here, or a thrombus which is lodging itself on the top of the basilar artery. So in the top of the basilar artery syndrome, what are the characteristic features that you're going to find? What are the important structures here? It is your midbrain and thalamus. So there can be bilateral midbrain, pons, thalamus involvement, and sometimes even your temporo-occipital region, depending on how much area of infarct is there. Okay, so in your top of the basilar artery syndrome, you can have bilateral midbrain, pons, thalamus, temporo-occipital region involvement. So what happens? What are the characteristic features of this top of the basilar artery syndrome? There is vertical gaze palsy. Okay, they can have bilateral corticospinal tract involvement. They can have bilateral corticospinal tract because the corticospinal tract comes down in the midbrain, right? Bilateral involvement means they will have quadriparesis. They will have quadriparesis. Okay, they can have drowsiness, stupor, and a type of mutism where they will not be able to talk and they are not able to move as well. So this is a very, very, very devastating condition because the patient is able to understand everything, unable to talk, unable to move, right? Unable to talk, unable to move. Okay, so this quadriparesis where, and they can have vertical gaze palsy and akinetic mutism, which is seen in your top of the basilar artery syndrome, right? So this is also compared to what we call as the man in a barrel. Man in a barrel. Why? Because it looks like the man is put into a barrel and he is not at all able to move, right? Because he cannot move his legs and arms. So this is your top of basilar artery syndrome. Then the next very, very characteristic feature, which is a very rare syndrome but very interesting syndrome, is your alexia without agraphia. Okay, so we have learnt about alexia with agraphia. Now we are learning about alexia without agraphia, and what is the difference we will look at here. So what is the lesion in your alexia without agraphia? Where is the lesion? So as it is highlighted here, it is predominantly your right PCA or non-dominant lesions. So your right PCA or non-dominant lesions, so right occipital lobe plus splenium of corpus callosum. Right occipital lobe plus splenium of corpus callosum. So you have right occipital lobe plus splenium of corpus callosal involvement, which results in this. So why is there alexia without agraphia? So let us understand this very important area that we call as the angular gyrus. We had seen the angular gyrus in your MCA territory as well. It is just present above it is present in the parietal lobe just as when the superior temporal gyrus leads into it. So the angular gyrus is basically involved in reading and writing. Okay, so whenever you are reading something, for example your left eye, okay, you are reading with your left eye identifies it, then the impulse is transported to the left occipital cortex. It is transported to the left occipital cortex, and through this area, this is a very, very important area, which is your splenium of the corpus callosum. Through the splenium of the corpus callosum, whatever you are reading in your left field is transmitted to the right angular gyrus. So this is very, very important. So whatever you are seeing in the left side, or reading in the left side rather, not seeing, it goes to the occipital cortex, crosses the splenium of the corpus callosum, goes to the right angular gyrus. So whenever you have a non-dominant, that is your right occipital cortex plus splenium is affected as highlighted here, right occipital cortex and splenium is affected, then there is a dissociation. What you are reading on the left side cannot go to the right side. So there is alexia, correct? So there is alexia. Fine. But writing is brought about by the ipsilateral angular gyrus. Writing is brought about by the ipsilateral angular gyrus. You do not require any crossover for writing, right? So angular gyrus is intact here. Because angular gyrus is intact here, your writing is intact. Then why reading is not intact? Because there is a disconnection in the splenium. The impulse from the left side is not getting transmitted to the right side for you to read. Okay, so you have alexia, but you do not have agraphia. But whenever you have an angular gyrus involvement per se, then both reading and writing are lost. So you have alexia with agraphia because whatever you are reading is not processed by the angular gyrus, correct? So here there is no processing at all. So you have alexia and agraphia. So alexia without agraphia is your right occipital lobe plus splenium of the corpus callosum. And very important associated feature, you will have a right-sided homonymous hemianopia with macular sparing. Clear? So this is your alexia without agraphia. Then the other characteristic named syndrome that we should know is your Balint syndrome. Okay, so we have two syndromes, one of which is your Balint syndrome. So this is because of bilateral visual association areas watershed infarct. So what do you mean by that? So what is the visual association? We know that the primary visual cortex is in the occipital lobe, and here you have the visual association areas, right? So the areas surrounding the primary visual cortex is your visual association areas, and as you know that this region is supplied by what? It is supplied by both the PCA and MCA, right? So there is a PCA, MCA watershed area, and an infarct here can cause a Balint syndrome. So what is the triad of features of Balint syndrome that you should know? One is optic ataxia, that means inability to identify the depth of a object, right? Whenever you are seeing, you can assess the depth, that is lost. Then we can have asimultagnosia. Asimultagnosia means inability to visualize more than one object in the visual field at once. So whenever you are seeing something, there are multiple objects around you. There is a tree, there is a car, there is a road, but inability to visualize more than one object in a particular visual field. Then third and the most important of the triad is your oculomotor apraxia. Apraxia means inability to perform a learned motor act, right? So actually here the extraocular movements is full, but the patient still does not scan the field. Okay, so that is the meaning of your oculomotor apraxia. So optic ataxia, asimultagnosia and oculomotor apraxia is the triad of features of Balint syndrome. The next syndrome that we should know is your Anton syndrome. Anton syndrome occurs due to bilateral PCA territory infarct. Okay, they have bilateral PCA territory infarct and they have a complete loss of vision and they deny blindness. So very importantly, what happens is that they deny blindness, so they keep bumping into objects, right? They do not have weakness, they do not have any other syndrome. So bilateral PCA territory infarct is Anton syndrome. Then artery of Percheron infarct. Now artery of Percheron is basically a very important anatomical abnormality where you have a single PCA. You have a single PCA. So if there is a single PCA, the midbrain, the reticular formation, all of it is by the artery of Percheron, and hence you will have upward gaze palsy and a dream-like state because of involvement of your midbrain structures and reticular formation. Okay, so that is your artery of Percheron. So with this, we have come to the end of our discussion on posterior circulation, and we have come to the end of our discussion on localization of anterior and posterior circulation strokes. I hope this is very clear. This was the most simplified version of your stroke syndromes. Right, so please go through this again and I hope you will understand this better. In the next chapter, we will be discussing about brainstem syndromes. Thank you.